diabetes do you know? Please don't tell me 5, 6, 7 types. Diabetes mellitus, diabetes insipidus. But if I ask you how many types of diabetes mellitus do you know? You need to say 6. That's the new classification I will show you today. The classification which was published in 2020, according to the new researches of WHO and new guidelines of European, Russian, and American endocrinologists. Now we have classically 6 types of diabetes mellitus. All of them, little bit. I will tell you a little bit about all of them. Please remember this. And of course, in practice classes, I will ask you to show me lecture conspects, because I know that some of you do not write lectures. Please make a screenshots of the lectures and then copy them into your notebooks, because some information you may find only in the lecture. Not everything, of course, it's just a summary, but some, for example, classification will be only in the lecture. Here I have a statistics about Indian, but same prevalence of diabetes you may find as in Pakistan, as in Bangladesh, as in China, as in China. In that countries, South Asia region, the problem of diabetes is very high now. It's a very big problem, because unfortunately, people of South Asian region have a specific predisposition, genetic predisposition, specific type of nutrition, high carbohydrate diet, and especially to type 2 diabetes. So among adults, this problem spread nearly in 17 to 18% of all cases of all people. This is a really high quantity of people, because every 10th person has, imagine that every person among adult people, every 10th person has, why 10th? Every 5th person have type 2 diabetes mellitus. The problem is that in 0.5% of cases, 50%, 47 to 50% of people with diabetes mellitus don't know about their disease. They are lately diagnosed, and that becomes a big problem, because these people, they don't know about their disease. They continuously eat everything they want. They continuously do everything they want. I mean, they don't have healthy lifestyle. They don't take care about themselves. And diabetes mellitus slowly kills their organs. So when we diagnose diabetes mellitus type 2 in adult people, in 0.5% of cases, already patients have at least one complication of this disease. Diabetes mellitus now is one of the most important non-communicable disorders. Maybe you've heard from the other teachers that now we have 4 basic non-communicable disorders, which are the greatest problem in all over the world, and give us the highest percent of mortality. These are cardiovascular disorders, COPD, diabetes mellitus, and cancer. I just tried to do this small video. I'm apologizing if it's not very good, but unfortunately, I cannot find what I want in the internet. And so that's why I tried to little bit to explain by myself. Usually I do that in class on Blackboard, but because still we have lectures online, I want to show you here on the slide. So I will explain. Please listen, because to understand diabetes mellitus, you need to understand normal physiology of carbohydrate metabolism. If you do not understand it, you may not understand pathogenesis of diabetes mellitus, of type 1 diabetes, type 2 diabetes. If you don't understand pathogenesis, you may not understand treatment. Because internal medicine, which you have now, all diseases are close to each other, they stay close to each other, and you will repeat them in 10th semester, and then finally in your GOS exams. So you come to our department. So our department teachers from our department all will present in your final exam. So normal physiology. So if something with the screen, if you don't see it, if you don't see how I change slides, please tell me immediately. So to understand carbohydrate metabolism, look at the organs which are shown on the screen: GIT, pancreas, liver, muscles, adipose tissue, and nerves. Everything starts from food when we eat. I think that all of you had the breakfast today, and maybe some of you had already lunch. We have in our food, we have 3 basic components: carbs, proteins, and fats. Carbohydrates consist of 2 main carbs, simple and complex. Proteins, fat, consist of saturated and unsaturated fats. Let's speak about carbs. When we eat carbs, our pancreas digests it with the help of exofunction, with the help of enzymes. 3 types of enzymes: amylase, lipase, and protease, or it is also called trypsin. So amylase, the enzyme which digests carbs. With the pink color, it will be glucose to simple. We have few simple carbohydrates: glucose, fructose, lactose. The most important carb is glucose. So finally, all our food will be digested. All carbohydrates from our food will finally digested to glucose. GIT, look inside of GIT. We have receptors everywhere on each cells in our body, various types of receptors. The one of the receptor, it's important to ask, please make a note somewhere. This is the receptor to glucose. It's sensitive to glucose. It's called GLUT, G-L-U-T, GLUT receptor. This receptor absorbed glucose onto each surface and transported it to the organs, into blood. First organ will be liver, then adipose cells and muscles, and of course, nerves, because central nervous system, our brain needs glucose. We cannot live without pure glucose, as we cannot live without oxygen. So on these cells, nerves, muscles, and adipose and liver also, you also may find receptors to glucose. Their name is also GLUT. Various types. Now we know more than 12 types of GLUT receptors for the different organs. In pancreas, there are also GLUT receptors, because pancreas, it should understand how many insulin it will produce for this glucose level. But let's come back to GIT once again. So look inside the GIT cell. If you look inside the GIT cell, in the thin intestine, duodenum and ileum mostly, you will find there this system, orange color, the system of internal peptides, which are called incretin. Incretin cyst, also make a note, it will be important in treatment. For understanding of treatment of type 2 diabetes, this system is very important. This peptide, this system produces peptides, which is called glucagon-like peptides, according to glucose influence. Look, glucose stimulates secretion of glucagon-like peptide, and together with the glucose, GLP, glucagon-like peptide, plus glucose, spread it to pancreas and stimulates secretion of insulin, basic hormone of pancreas. So, I will stop the video. Just understand this, that when we eat our pancreas produces insulin. It produces insulin. Before meal also we have insulin secretion. Our pancreas always produces insulin every second. But the level of insulin gradually increases when we eat after meal. It happens because the level of glucose in blood increases and because our GIT cells produce peptide, which is called glucagon-like peptide. This peptide is responsible for postprandial, remember this word, it's after meal, but more correctly to tell postprandial glucose, postprandial insulin secretion. So 60% of insulin produced because of GLP activity. So insulin, it's a specific hormone. This is the protein hormone with 2 chains. When we do not eat, when we don't eat 24 hours, look at the daytime. When we don't eat, if we don't have opportunity to eat, we have classes, when we sleep, maybe some people have they're fasting due to some reasons. We call this insulin level basal. Anyway, pancreas produces insulin because without insulin, liver will produce glucose. This is basal. But anytime when you eat any carb, the level of insulin increases. It's called prandial secretion. So pancreas produces insulin in 2 regimes, basal and prandial. Why I explained that? Treatment will depend on these 2 regimens, types of insulin. You will use these names. So where it produces insulin? Into blood. From blood, insulin is spread to the same organs where we need glucose. Look, liver, adipose, and muscles. And in these tissues, there is another type of receptors, green color, insulin receptors. These are insulin receptors. What does it do in these cells? It opens cells to glucose. Glucose can easily come in to the cell, and these cells, they use glucose for production of ATP. But look, please, our nerve cells, they do not need insulin for glucose entrance. We call these tissues insulin independent, and tissues where we need insulin, liver, adipose, and muscles, insulin dependent cells or insulin dependent tissues. So these cells, we need insulin for glucose activation. For what? For ATP, energy, basic. So why do we need insulin? For secretion of ATP from glucose. Glucose converted to glucose 6-phosphate with the help of insulin, but not everywhere. In nerve cells, in the cells of vessels, cells of connective tissue, this process started without help of insulin. That's very important to understand pathogenesis of diabetic complications. So in this picture, you see it's a very easy normal carbohydrate metabolism. I mean, it is showed you in the easy way what happened, but unfortunately, it's not as easy as here. So look at that picture once again. What I told you about incretin system. Food, and after food intake, in GIT tract, in intestine, produced incretins. Incretins, glucagon-like peptide, most active incretin. Look at the right part of the slide. Glucagon-like peptide, it is effect. How it is effect? It is, first of all, it effect on beta cells. It produces, stimulates secretion of insulin. And how it is effect on alpha cells? It is decreased secretion of glucagon. But look at the small square on the right side of the screen. So the action of incretins are limited because they are rapidly degraded by the enzyme. It is called DPP4, dipeptidyl peptidase 4. This is the enzyme in our GIT. So how it happens? We eat, incretins secreted, they stimulate pancreas, pancreas produces insulin, DPP4 destroys incretins. When we eat, once again, everything repeated. So why it's important to remember? We have a type of medications which can intensify effect of incretins and which can suppress DPP4 enzyme. Also, it's about our second lecture today. So if you look at that slide, the various levels of glucose and insulin in the blood. So red color is the glucose, blue color is insulin. Look how the quantity of glucose depend on quantity of insulin depend on quantity of glucose. They're absolutely equal. One by one, insulin goes step by step after glucose. It's a normal physiological reaction. So what is diabetes? Unfortunately, diabetes mellitus is a group, it's not one disease. This is the group of disorders which characterized by elevation of blood glucose due to their defect in insulin secretion, defect in insulin action, or combination of the both conditions. Diabetes mellitus, it is an aggressive chronic disease which finally provokes damaging of internal organs like heart, kidneys, nerve system, and the vessels, and provide failure of various organs. If you already finished nephrology, if you already finished cardiology, I suppose the teachers told you that chronic kidney disease, the main reason is diabetes mellitus. Stroke and amine, one of the main reasons is diabetes mellitus. So as I said, now we have 6 types of diabetes mellitus. It is type 1 diabetes, which you discussed in your pediatrics endocrinology. Type 2 diabetes mellitus, it will be our basic topic in on our classes. Hybrid form of diabetes, other specific types, unclassified diabetes, and the last group, hyperglycemia, first detected during pregnancy. So let's start from that. So type 1 diabetes mellitus, what is it? We'll come back to this. Type 1 diabetes mellitus, it's the situation when our body mistakenly attack beta cells, mistakenly attack pancreas, and immune system destroys beta cells. Usually, the disease develops in childhood and early, and maybe sometimes in adolescence, and sometimes in early adult age. This is the autoimmune disease. Type 1 diabetes is autoimmune disease. So when you look at the prevalence, it is more spread among children. Excuse me, just make some notes. I should answer the question. Да? Excuse me. So let's come back. Type 1 diabetes, it is an autoimmune disease, autoimmune. It's usually it starts in young age, but people with type 1 diabetes, they may live a long life. And if you see adult person with the diabetes, always ask, when disease started and which age the disease started, because it's very important, age of manifestation of the disease. Type 2, look again to this slide. It's the most common type. 90 to 95% of all diabetes, which you will see in your practice, it will be type 2 diabetes. Look at the description of this disease. Various degrees of beta cell dysfunction, not destruction. It's a big difference from type 1. Type 1 diabetes, destruction. Type 2 diabetes, dysfunction. And insulin resistance. Resistance means no opportunity, no sensitivity to the own insulin. Commonly associated with overweight and obesity, but sometimes may present without these two factors. So, type 2 diabetes. In type 2 diabetes, you may find the risk factors. The first and the most important risk factor is obesity and overweight. Then next risk factor is age, more than 45 years old, but also make a note, among South Asian population, this age is earlier, more than 35 years old. Obesity, family history of diabetes, presence of diabetes during pregnancy before physical inactivity, smoking, the presence of various cardiovascular diseases, elevation of cholesterol and blood pressure. Usually it started from insulin resistance. Cells in the organs like liver, adipose, and muscles. So where we need insulin? Come back to the video which I showed you. These cells are not sensitive to the own insulin. Why it happens? Due to that risk factors. Due to the obesity, free fatty acids, they damage insulin receptors, and receptors are not responsible to the own insulin. During this moment, so people with insulin resistance may not have type 2 diabetes for many years, but finally, when we have insulin resistance, pancreas should produce more insulin to overload this insulin resistance. Finally, beta cells lost ability to produce enough insulin, and we will see dysfunction of beta cells on the moment of type 2 diabetes manifestation. So the higher body mass index is, the higher is insulin resistance. Please remember that if you see BMI more than 35, this is there. In 100% of cases shows us that there is insulin resistance. Also, make a screenshot of this slide. It's a whole pathogenesis of type 2 diabetes. In type 2 diabetes, in the middle of this slide, you may see, so number 1, pancreatic beta cells. Beta cell function decrease, mass of beta cells also decrease. Why it happens? Look please in the left part of the slide. Stomach, number 10, small intestine, increased rate of glucose absorption, abnormal microbiota, number 8, decrease of GLP-1 secretion. Look in the middle once again, number 2 and number 3, decrease of incretin effect, alpha cell defect, increase of glucagon secretion, and look in the down part of the slide, number 11, increased glucose reabsorption in the kidneys. All these provoke hyperglycemia and formation of the symptoms. This slide, what's the difference between that and that next slide? By blue colors, you may see various medications which we can use in this or that pathogenetic key moment. We will come back to this slide. So continue with classification. Hybrid forms of diabetes. Hybrid means mixed forms. impossible to understand. This is type 1, sometimes very difficult to understand what type of diabetes in front of us look like type 2 diabetes, but patient has ketone bodies. Ketone bodies are specific for type 1, look like type 1 diabetes, but person can live without insulin for some months. It was shown that this diabetes is we call it hybrid forms of diabetes. It's a various genetic abnormalities of diabetes, and now we classify it in these two new groups. Two types here: slowly evolving immune-mediated diabetes of adults. It is very similar to type 1 diabetes, but it is slowly progressive type of autoimmune abnormality and beta cell destruction. And second type, ketosis-prone type 2 diabetes, people with ketosis and insulin deficiency, but they do not need insulin at the beginning of their disease. They have sometimes episode of ketosis and sometimes could be treated by type 2 diabetes. Next group are the specific types. You see here how many disorders present. Other specific type of diabetes, we also call it secondary diabetes, but better to call it other specific types. It's a group of diabetes mellitus. Genetic diseases, monogenic diabetes, disease of exocrine pancreas, like some trauma, tumor, inflammation, etc. Some endocrine disorders. These classes, in our classes, I will tell you about Graves' disease, Cushing syndrome. All these conditions may stimulate diabetes mellitus. Some drugs, some infections, which may destroy beta cells, and some genetic syndromes which are associated with diabetes, like Down syndrome, like Moon syndrome, Moonabadl-Beadle syndrome. There are a lot of various genetic syndromes which are also associated with diabetes mellitus. So once again, here it's close to the previous slide, specific types of diabetes. But here I showed you how drugs can affect on insulin action and insulin secretion, for you to remember what medications may provoke formation of secondary type of diabetes or other type of diabetes. Then group number 4, group number 5, unclassified diabetes. Yes, there is this type of diabetes. If we do not know what do we see, if we don't understand, absolutely we cannot understand what type of diabetes in front of us, you may put diagnosis unclassified diabetes. And the last one, number 6, hyperglycemia, first detected during pregnancy. Here also there are 2 types. Diabetes mellitus in pregnancy. It may happen that pregnant women, their diabetes type 1 or diabetes type 2 started firstly in moment of pregnancy. But it may happen that pregnant women may have gestational diabetes. The difference I will show you in the next slide. So what is gestational diabetes? The form of glucose intolerance that is diagnosed in some women during pregnancy, more common among obese women and women with a family history of type 2 diabetes. And this type of diabetes disappears after delivery. So after delivery, disappears, is gone. So it disappears, no diabetes. But the pathogenesis of this condition is the same as in type 2 diabetes. But in the moment of pregnancy, these women, they have elevation of estrogen and progesterone. These 2 hormones, they suppress insulin secretion and insulin action. And if they have predisposition to type 2 diabetes, their glucose level is increased. We call it gestational diabetes. But then after delivery, in 20 to 50% of cases, in 5-10 years, these women, they develop type 2 diabetes. So As I said, I will show you when we start diagnosis. I will show you how to understand. If you look at the pregnant women, this is type 1, type 2 diabetes, or it is gestational diabetes. So general, about symptoms, general information, symptoms of diabetes are specific. So they are, of course, 3P symptoms: polyuria, polydipsia, polyphagia, because remember, glucose we need for ATP. If there is no insulin or insulin, the problem in insulin action, our body uses another energy metabolites like proteins and fats. That's why person lost weight because of frequent urination. Glucose filtrated with the urine and increases osmotic pressure of urine. Urination increases and thirst present, loss of water. Weight loss present, blurred vision, skin infection, slowly healing of wounds. But look in the end of the slide, type 2 diabetic patients can be asymptomatic. That's the difference between symptoms of type 1 diabetes and type 2 diabetes. In type 1 diabetes, symptoms are very classical. Symptoms develop quickly in few days. Person can come to you and tell you the data of symptoms of beginning of this, when the symptoms start. Type 2 diabetic patients, they do not know when their disease starts. They cannot tell you data because they do not have high glucose at the beginning, and they do not have classical urination, elevation of urination, classical thirst. So they may have diabetes for many, many years, and they may not know about it. It's a specific. What you will do with this? Also, for diagnosis, you will search for diabetes. That's why we should check. We should check people with in group of risks. In group of risks. So for diagnosis, what do we use? We use fasting plasma glucose, which is a blood glucose measuring after 8 hours of fasting. We use oral glucose tolerance test, or GTT. It's a blood glucose measured 2 hours after drinking very sweet solution of glucose, 75 grams of glucose. Also in practice I will show you, and we will try to check glucose level by glucometer. But in diagnosis, we should not use glucometer. We should use a laboratory examination. 75 grams of glucose. So how glucose powder look like? It is look like sugar powder. If you sometimes use it in cooking, you may understand. It's a white powder, very sweet. 75 grams. It's approximately 4 tablespoons. So this quantity of glucose should be diluted in 1 glass of warm water. And after 2 hours, post drinking that solution, we again measure glucose. It's called glucose tolerance test. The next type of test is glycated hemoglobin HbA1c or A1c. It's a form of hemoglobin. It's bound to glucose very closely without. So this hemoglobin cannot transport oxygen anymore. Glucose concentrated on the surface of hemoglobin. We call it glycated hemoglobin, and it will show us the average level of glucose in the blood. Please remember, what is it? Glycated hemoglobin, nowadays used everywhere. It's a very spread type of test. And tests, we can examine it one time in 3 months. And random plasma glucose used in patients with symptoms of hyperglycemia or if it is some crisis. Please make a screenshot of this table. I will ask you that in practice. You have it in your MCQs. Of course, you have it in your exams. Diagnosis of diabetes and pre-diabetic conditions. Look down, please. Look at the down part of the slide, IFG. On the right part, it is written. What does it mean? Some students, they do not pay attention on it. On the right part of the slide, transcription of and meaning of these letters. IFG, impaired fasting glycemia. Impaired fasting glycemia, according to the name, impaired fasting glycemia means that glucose level increase before meal. After meal, glucose is normal. Then, next, IGT, impaired glucose tolerance. It means that before meal, glucose is high, and after meal it is also high, but not enough to put diagnosis of diabetes mellitus. And the upper part, DM, diabetes mellitus. The glucose level in the fasting period is higher than 126 mg per deciliter, or after meal or postprandial more than 200, we call it diabetes mellitus. A1C level more than 6.5%. If type 2 diabetes is asymptomatic, how you will understand who is have it or who does not. For this, we will examine everyone, all people, not only patients, all people. But whom you will examine? Look, all adults after 18 years old with BMI more than 25 and one or more risk factors, and all adults without risk factors, just all people after 45 years old should examine their glucose at least one time in 3 years. If they have pre-diabetic values, IFG or IGF, they should examine glucose level once a year. So we can use fasting plasma glucose or A1C test, no problem. You may do whatever you want, but the cheapest way, it is examination of fasting plasma glucose. So if you see elevation of fasting plasma glucose or elevation of postprandial glucose, according to the previous table, you need to repeat test once again after a few days to prove, to confirm that diagnosis. Gestational diabetes and diabetes primarily detected during pregnancy. So look, who we should examine. All pregnant women at the first visit to gynecologist and 24-28 week of gestation. So fasting plasma glucose more than 90 but less than 126 shows you that it is gestational diabetes. After 2 hours, if it is more than 144 but less than 200, shows you that it is gestational diabetes. If it's more than 126 or more than 200, it is type 1 or type 2. It's not gestational. That is the difference. Again, once again, in practice, of course, we will repeat it. Please make a screenshot of literature. Some of this literature I will send you. Some of this literature you should find, but better you have to find it by yourself. First book I will send you, Williamson textbook of endocrinology. It's the main book which you should use for preparation to endocrinology classes. Do you have any questions about classification of diabetes and about diagnosis of diabetes?
No, ma'am.
Please.
No, ma'am.
No, ma'am. Everything is so clear. Yeah, everything is clear.
No, we will study. Then later on, maybe if you have any confusions, we'll discuss in practice.
Okay. Thank you, David. Well, okay, then let's continue. Management of diabetes, also few slides, and then you may have a rest. So, and treatment. Also, I give you only basic summary. I don't have too much time to explain you, for example, lifestyle modification. This is it's a very big lecture, and I may speak about this more than 3 hours, but basic information you will have now. Treatment of diabetes, any type, we have 5 basic key points. Lifestyle modification, which includes diet and exercise, medications, self-monitoring of blood glucose, control of blood pressure and lipid level, regular complication monitoring. So before that, before treatment of diabetes, we should understand that all people with diabetes mellitus who already know about the disease, to whom we already put the diagnosis, we need to tell them their target level of blood glucose. Don't tell me, please, that they should have glucose as a health people. It is a wrong. It's a wrong information. It is correct only to children, adolescents, and pregnant women. For people with type 2 diabetes, for elderly patients, target level of blood glucose should be higher than in health people. But we should look at the A1C level, how to understand what is the level of A1C and what's the level of glucose. Also on practice we'll speak. Please remember that people with diabetes, most of adult, we do not speak about children and adolescents. It's not our topic today. We are on adult endocrinology. Adult people with diabetes, most of them should have HbA1c level less than 7%. Normal level less than 6. Diabetic criteria more than 6.5. Target level for people who already know about diabetes mellitus less than 7% for the most of them. But sometimes we may increase this target level. For example, if we see person, elderly patient, 18, 19 years old, with cardiovascular disorders, with poor control, we may increase this level to 8%. In some cases, if we see young person, less than 45 years old, without any complications, we should tell to decrease A1C level less than 6.5%. But it is a personal. We need to choose this target level of A1C personally. First of all, diet. Only specificity of diet in few words. So, first of all, when we eat 3 types of products: fats, carbs, and proteins. Fats. Diet for diabetic patients is the same as for health people. What do I mean? We call it healthy nutrition. we all of you and me too, we have healthy nutrition. Fats should be restricted a little bit, decrease of the quantity of saturated fats, of fatty meat, or some saturated fats from dairy products like ghee or butter, so it's a ghee, and better to use unsaturated fats. Saturated fats, they also should be present, but less than 10% of all daily intake, and mostly better to cook on vegetable oil, to use vegetable oil, and to eat non-fatty meat, to eat people who are vegetarian, to eat fish, and to avoid very fat products, especially fast foods. Proteins should present. Protein you may find in who are not vegetarian, in meat, of course, in eggs, in dairy products, in mushrooms, who are vegetarian, in mushrooms, in beans, various types, soya, kidney beans, etc. Everywhere, protein present as in vegetarian, as in non-vegetarian products. But it should present 25% of 10 to 15% of energy, but altogether 25% of all products which we eat in a day. Also in practice, I will show you. It's called, well, if you are interested, you may find the information. It is called Bristol plate. The rule of the the rule of the Harvard plate. This is the visually information about how many we should eat carbs, proteins, and fats. Also in practice, I will show you. And carbohydrates. Carbohydrates should not be avoided. People with diabetes, they should eat carbs. Look, 50-60% of total caloric. But what type of carbs? Complex carbohydrates. No simple, no sugars, no candies, no cakes, no chocolate, no some sweet juices, no cola and Fanta, etc., etc., no soda. So club soda, I mean. All these products contain simple carbs. Simple carbs are restricted, but complex carbohydrates like fruits, vegetables, some products with grain like bread with the starch, with fibers, should present half of the ration. So half of the cousin contain of the products which we eat daily should contain complex carbs. Salt should be avoided. Less salt help us, first of all, to decrease edema in the body, second, to decrease blood pressure and weight. Exercises. Second rule, physical activity should be continuously, it should be regular. Regular means at least 3 times a week or 30 to 60 minutes per day, but it should be regularly. That means if you, for example, walk 15 minutes to your classes and then 15 minutes after your classes, it is not continuously. So this should be, so duration of activity should be at least 30 minutes every day. We should educate people with diabetes. There is one problem. They may have hypoglycemia. So that's why we educate them what to do if they use insulin. They may have rapidly decreasing of their glucose during physical activity, because when muscle walks, it uses glucose. So we educate them to have with themselves glucometer and examine their glucose if they feel symptoms of hypoglycemia. And medication, next step. Type 1 diabetes, only insulin. It could be basal or plus Prendel, it could be insulin pump, it could be insulin syringe, but it will be only insulin. Unfortunately, we don't have any other medication for treatment of type 1 diabetes. If you tell me that in treatment of type 1 diabetes, you will use some drug, maybe metformin, it means that you do not understand pathogenesis of this disease. Type 1 diabetes, it is absolutely insulin deficiency. It's a destruction of beta cells. Please remember it, destruction of beta cells. Beta cells are gone, they're not produce insulin. That's why you will give insulin injections. Of type 2 diabetes, we may use various anti-diabetic drugs and also insulin. So on this slide, you see types of insulin which we have. I did the slide previous year. This year we have one or more insulin in Prendel group. That is the basic insulins which you see. Look at the upper part, basal group, and look at the down part, Prendel group. Why I explained you types of insulin secretion? Because according to this, we have insulin, artificial insulin. It's not artificial, it is a human insulin. It is produced by Escherichia coli, by a genetic modified gene, which is located into the DNA of Escherichia coli, small bacteria. And this bacteria produces, in factories, produces insulin, human insulin. But then to change, we can change the structure of this insulin and to give to various insulin various time of action. So the longer action is, the better for patient, because less injections should be done. And we call this insulin basal. Look, duration, for example, of degludec or detemir, up to 24 hours and more. Prendel insulin is the opposite situation. We need to decrease quantity, we need to decrease time of action And that's why the insulin like Aspart, Lilizyme, Lispro, look, they can be injected before meal and very quickly digest all carbohydrates from food. Among all that types of insulin, make a note, regular, look, in prandial group, regular insulin. That insulin is absolutely same in each structure as our own insulin. And we use it, only this insulin, regular, we can use in treatment of emergencies in diabetes also. Second lecture will start from this. So if you look at this slide, you may see that how insulin acts in the body. This is this after injection. It is artificial insulin after injection. So if you look at the down part of the slide, pre-mixture, we also have insulin can be injected in pure type. It could be pure basal or pure prandial insulin, or also it could be mixtures of insulin in one syringe to various type of insulin, a basal, for example, plus prandial. How to do insulin? By insulin syringe and insulin pen or insulin pump. And now I think you may have rest. I also need to have rest because it's very difficult to speak so many times without rest. And at 4 o'clock, once again, the same link, please connect, okay?
Okay, ma'am.
Okay, ma'am. Okay, ma'am.
Please, everyone. See you.
Okay,
See you.
ma'am.
See you, ma'am.
See you.